All right, this lecture is going to cover a few acquired cardiovascular disorders. Hypertension and dyslipidemia are seen in adults and should be a bit of a review for you. The other two, endocarditis and Kawasaki's, I'll go into a bit more detail about. So pediatric hypertension doesn't bring a whole lot of new ideas to the table. We have primary hypertension, which has no known cause, or secondary, which can be caused by underlying issues, medications, and obesity. Risk factors include those that are modifiable, like diet and physical activity, and those that are non-modifiable, like genetics and family history. So while hypertension in kids is declining, it still occurs in 1 in 25 youth. So continuing to screen, educate, and prevent is crucial to long-term continuation of this trend. Kids with hypertension are often asymptomatic, so we will screen all kids after age 3 at their well child visits, and any child that has an elevated reading will be screened more frequently. And then if they have 3 visits with elevated BPs, then a diagnosis will often be made. It is important as the nurse to ensure proper blood pressure cuff sizing for this reason. If it's too small, you will get an artificially high measurement. Treatment for hypertension is the same as for adults. We're looking at diet and lifestyle changes and then advancement to pharmacologic treatments if necessary. Kids should be encouraged to get physical activity each day by playing outside or participating in sports and minimizing screen time. Okay, so once again, this doesn't change much from adults to peds. Dyslipidemia is an imbalance of lipids, triglycerides, and cholesterol, which is often caused by genetic factors or obesity and underlying disease. About 20% of children aged 6 to 19 have abnormal lipid levels, so we begin to screen for this around age 9 with a lipid panel. Treatment is similar for hypertension, right? We have lifestyle modifications and then meds like statins or cholesterol absorption inhibitors if needed. So infective endocarditis is an infection of the inner lining or the endocardium of the heart, and this usually involves valves, which I mentioned when we were talking about prophylactic antibiotics for congenital heart kiddos in the earlier lecture. Your causative agents here would include strep viridans, Staph aureus, and Candida albicans. These pathogens adhere to the injured endocardium, and then the platelet and fibrin deposits will create a barrier around that bacterial growth, making this really difficult to treat. As you can imagine, any procedure that implants something into the heart will increase the odds of infection that can seed that area. So in addition to congenital heart defects, implanted valves and stents are also a big risk factor for endocarditis. Patients will present with signs of infection, such as low-grade fever, malaise, and loss of appetite, maybe some joint pain. Symptoms can be very nonspecific, especially in babies, right? So we have feeding intolerance and respiratory distress, which are kind of in line with those heart failure symptoms that we see in defects. So in this patient population, in these heart kids, it's important that we take any fever or fatigue very, very seriously since they are at such high risk of endocarditis. To diagnose it, we can do an echo that will show new or increasing valvular insufficiency, vegetations on the valves because hearts don't like salad, abscess or decreased ventricular function. You could use a blood culture to rule out endocarditis, and then other common labs that we could use would include CBC, ESR, and a urinalysis as well. Treatment for endocarditis is high-dose antibiotics for 2 to 8 weeks based on the causative microorganism. So hopefully you get that blood culture back pretty quickly and we treat it properly. Infusions of this length will usually require the placement of a PICC line. Surgical intervention may also be required for heart failure or valve damage. And again, it's really important that these families know about prophylactic antibiotics during dental work because that soft tissue manipulation can introduce bacteria into the body and easily get to the heart. Now, Kawasaki's disease is a straddling disease because it technically is an inflammatory condition that has potential effects on the heart. However, ATI put it in cardiac, so here we are. It's a body's response to an unknown respiratory pathogen. So some ideas are that it can come from staph or strep or mycoplasma or even adenovirus. The risk factors for Kawasaki's is generally a child under the age of 5. Usually I've clinically seen them about 3 to 5 years old, male with a higher incidence in Asian and Pacific Island descent. It shows up in 3 phases. Acute, subacute, and convalescent. The acute phase is what you will see in the hospital where these patients have intractable high fevers for several days and they don't respond to antipyretics. This really is a diagnosis of exclusion, but some of the symptoms are pretty specific, such as lots of things looking red. Your eyes, your lips, your tongue, hands and feet. The biggest concern here is the effect on the heart, which is also red, since coronary artery inflammation can occur. These kids will generally get an echo to ensure that no damage has occurred, and then treatment should also begin as soon as possible for this reason. And the treatment for Kawasaki's is IVIG. Usually 1 to 3 doses will sufficiently reduce the inflammatory response. This is one of the only reasons that we use aspirin in peds, and that's because the benefits outweigh the risks. We use them to reduce aneurysm. All right, they'll usually be started on a fairly high dose of aspirin, and then that will continue as a low dose regimen after discharge for about 6 to 8 weeks through that convalescent phase. And they will also have a cardiac follow-up to get a second echo about 4 to 6 weeks after treatment. To see if there was any damage. If damage has occurred, that aspirin therapy may actually be continued indefinitely. So this concludes the lecture on acquired cardiac conditions. Have a great day.